Hola a todos, bienvenidos a esta reunión de Meet the Expert, en este caso con el profesor Toni Choueiri, que nos acompañará durante las próximas casi 2 horas con nosotros. Bienvenidos. Hola Álvaro, ¿cómo estás?
Hola, ¿qué tal? Muy buenas tardes a todos.
Javi, ¿qué tal, tío?
Hola, Quique. Buenas tardes.
Bueno, en este caso os recuerdo cuál es la dinámica cuando hacemos un Meet the Expert. Va a haber 2 presentaciones del doctor Toni Choueiri. Una primera, que nos centraremos sobre los nuevos datos que tenemos en la primera línea del cáncer de riñón, focalizados sobre todo en el Checkmate 9ER. Sabemos que el doctor Choueiri fue el investigador principal de este estudio, hizo la presentación presidencial en la ESMO, ¿no? O sea, que nadie mejor que él para discutir y desgranar el estudio en detalle. Y luego haremos una discusión de unos 20-25 minutos, seguida de una segunda charla nuevamente de Toni Choueiri, en el cual nos hablará sobre cuáles son los nuevos fármacos, los nuevos diseños de estudio, los nuevos biomarcadores que tenemos en el mundo del cáncer de riñón y cómo ve él la terapia del cáncer de riñón durante los próximos 10 años, ¿no? Yo creo que va a ser una excelente reunión, seguro. Es difícil asegurar un éxito de una reunión y en este caso yo creo que lo podemos asegurar. Obviamente el contenido tanto de las presentaciones como de la discusión va a ser en inglés, pero vais a poder todos hacer las preguntas que queráis. Sabemos que tenemos el chat, tanto Álvaro, Javi y yo lanzaremos esas preguntas al doctor Choueiri y no seáis tímidos, interaccionar todo lo que queráis. Sabemos que es una excelente persona, mejor aún médico, es un innovador en este campo del cáncer de riñón y para nosotros, para el Grupo Centro, es un auténtico honor tenerle aquí. Now let me switch into English. So, Professor Toni Choueiri from Harvard, from the Dana-Farber, Boston, how are you doing with them? I know that you are a Barça supporter. Maybe this is not a good idea here because most of us are coming from Madrid, but, well, this is up to you. So, okay, you can start whenever you want.
I'm glad we're doing it in Zoom, not in person. You know, one of the silver lining. Otherwise, I would be beaten up. I know that.
You know, I suggest you are connected to Twitter because I will do 2 things. I will put 2 pictures together, you know, and you will need to find the difference in between these 2 pictures. You will like it.
Well, I'm very pleased to be here today. I consider Dr. Grande, Puente, and Pinto as not just colleagues, but as friends. Unfortunately, the pandemic separated us for 9 months, and we don't know for how long, but I'm glad to be part of this very important symposium. So thank you for having me today. Do you want me to share my screen, Dr. Grande?
Yes, please. Be ready. Yeah, whenever you're ready, let's go.
Perfect.
That is great.
So, perfect. So I was tasked for 2 things. First, to dissect the most recent trial that was presented in Europe at ESMO 2020, and it was the Checkmate 9ER, and we're gonna go over 20 to 30 minutes dissecting this. You can interrupt me anytime. And then the second part of the symposium, we are going to see what hopefully the next 2 to 3 to 10 years gonna be in renal cell, looking at the most upcoming trial that are still not reported, some accruing, some are planned, some finish accrual, as well as the totally novel target, since all of us are a bit sick of immune checkpoint blockade and VEGF TKI, what else there is. So let me start by Checkmate 9ER. These are my relevant disclosure. Part of this was presented during ESMO 2020. And we all know that nivolumab is an immune checkpoint blocker. Cabozantinib is a TKI involved in targeting not just the VEGF receptor, but also MET and XL, which are kinases that are involved in VEGF resistance. And cabozantinib and nivolumab are actually approved in renal cell cancer, but approved in the refractory setting post-TKI. Now, in the frontline setting, nivolumab is approved in combination with ipilimumab, and cabozantinib is approved as a single agent in intermediate and poor risk, both of them. The question here is, could there be any synergy combining both of these drugs? And so a phase 1 study showed that, first of all, like many things when we start to combine, that combination is tolerated with cabozantinib at 40 milligram, a lower dose than actually the dose in single agent trials. And this moved into a phase 3 trial by the name Checkmate 90R, with combining cabozantinib and nivolumab versus sunitinib. But before that, I want to show you one of the most recent. I don't want to go over frontline cabozantinib data. I want to show you one of the most recent publication about cabozantinib here with the Q-twist analysis. This paper just came from the CABOSUN trial. We know in CABOSUN, progression-free survival and response rate in this randomized phase 2 were superior with cabozantinib over sunitinib. But the quality of life data, if you want, the Q-twist, this is the first time this publication, I'm showing it in a meeting. So what I wanted to show here, the Q-twist, which is the time without symptoms of disease and without toxicity. And you can tease that out from the clinical trial. And this is the one in between here, this gray area between the black and the white. And for cabozantinib, this is superior to sunitinib, just by comparing, both of them. So I wanted to add that. Why? Because we're going to discuss some of the quality of life that's going to come with 90R. So this is 90R. This is the combination of cabozantinib nivolumab versus sunitinib in patient previously completely untreated with clear cell RCC. The primary endpoint was progression-free survival. Overall survival, response rate, safety was secondary endpoint. Going quickly through the baseline and the disease characteristic, if you look here, there isn't much you can see different than a population of untreated metastatic RCC, early 60s. Important to look at the IMDC prognostic score when we put this trial in context with other. Most of the patient had intermediate risk, 22-23%. That's a bit, in the range of axiavirumab study, Javelin 101, a bit lower than the Pembro-Axi study. And most of the common site of metastases are lung followed by lymph node, which is not uncommon, that's usual. And half of the patients were in US and Europe and half the rest. So this is the primary endpoint. These data have been, presented. It's easy to remember. The progression-free survival was doubled from 8.3 to 16.6 months, hazard ratio 0.51 for progression-free survival. If you start asking yourself, well, is there any subgroup that benefited more than other? All the hazard ratios here are less than 1. So the benefit was consistent across all subgroups. Some subgroup of interest here are the IMDC's subgroup here. Benefit across seems a bit more in poor risk. We don't know if that's, statistics, number of patients, number of events met or not. But at least the big picture here, there wasn't a subgroup way benefiting more than other with sunitinib, let's say, compared to the combination. A very important endpoint, a gold standard we consider in trials, is overall survival. That too was met. 40% decrease in the risk of death, hazard ratio 0.6 with the combination. And notice that the separation of curve happened even before 3 months. Very powerful statement. Now, is there any subgroup also that benefited more than others? You go here, you look at all the numbers, again, they're less than 1. So the benefit was consistent. You can see some differences where some subgroup seem to have benefited more than others in this study. Now, response rate was also doubled, 27 to 55%. These are objective responses that are centrally reviewed with a CR rate of 8% with the combination, higher than sunitinib. Faster time to respond, 2.8 months. The median duration of response is higher. An interesting thing here we see is the rate of progressive disease is in the 5% range, very low. So a lot of these patients did not have PD as best response, the vast majority. We'll discuss later on one of the implications why this is. And again, I'm not showing a forest plot, but the responses also was consistent with benefit with the combination over sunitinib in all subgroup. 95% of patients had any reduction in their tumor compared to 85% with sunitinib, and that's what are the waterfall plot. Now, what about investigator assessment? We showed the slide here again to emphasize the consistency between central review and independent analysis here. The hazard ratio is even lower at 0.46 with a PFS 19.4 months on investigator assessment and a response rate reaching almost 60% here. Now, patient had those reduction here, 56, almost similar, 56% on the combo, any dose reduction of cabozantinib or sunitinib, not nivolumab here. Treatment discontinuation were mostly due to disease progression. And if you look at AEs that led to treatment discontinuation only, it's 3.1%. And these are treatment related for both drugs. Nivo only 5.6%, Cabo around 7%, and around almost 9% with sunitinib. But the chance to have a side effects that is treatment related by the investigator judge that lead to stopping both drugs, sometime at the same time, sometimes subsequently, is 3.1%. Now, this is the safety summary. Looking at it, it seems somewhat similar, but there is no doubt here that at least the AST and the ALT increase is higher with the combination compared to single agent sunitinib, though the vast majority of these adverse events tend to be of low grade. Now, what about specifically immune-related AEs related to Nivo, of course? Luckily, all of these in 320 patients are low overall in terms of grade 3 or higher. Hepatotoxicity is around 3% here. So they're low. One way, since these remain somewhat subjective and redundant, how to report it, especially with attributing immune-related AEs, is looking at steroid. Besides treatment discontinuation is looking at steroid use. And overall, 19% of patients needed corticosteroid, defined here as the equivalent of 40 milligrams of prednisone daily or more. Now, if you look for how long, 4%, only 4% needed steroid for 30 days or more. That's another way, also a bit more objective, to look at immune-related adverse events. One of the things we're happy about is that health-related quality of life, patient-reported outcome, which is really the voice of the patient here, was reported at the first analysis. Usually with these phase 3s, we start seeing from the first presentation the efficacy and the safety data, rarely the quality of life. But interesting enough here, the quality of life was presented with the FKSI 19, which is 19 metrics, 19 symptoms, or a subset, which is the disease-related symptom, which is a subset of FKSI 19. It's 6. And if you can see with both improvement here versus deterioration, it seems like the combination, at least for FKSI 19, didn't lead to a detriment, maybe just the first one at week 7, but after that, it stabilized around baseline, where with sunitinib, there was a deterioration. And anything you see asterisk here, that's statistically significant overall for the LS mean. So for the least square mean. You look at the more specific and narrower quality of life here questionnaire with FKSI. Now with FKSI, there is a detriment in sunitinib, but there seems to be a bit improvement here, statistically significant at most timelines with the combination of Cabo-Nivo. 40 to almost 50% of patients had subsequent therapies. Not surprisingly, sunitinib patient had more immune checkpoint inhibitor, as you can see here. So in terms of summary, overall of CheckMate 9ER, the risk of progression of death was decreased by 50%, almost. The risk of death, OS, by 40%. The response rate was doubled with an absolute increase near 30%. There was no differences in any major differences or inconsistency, let's call it, in major subgroup. There were toxicities, there is no doubt, but the combination was well tolerated. And when you look at treatment-related discontinuation of both drugs, these were low. An important thing to mention that the patient-reported outcome really did favor the combination over sunitinib here. And I wanted, and I don't know, Enrique or team, you want to interrupt, discuss here. I just have a couple of slides. Just despite we do not like to compare across studies, as we all do, but we keep doing it because we have now 3 studies, one with Nivo-Ipi and one with Pembro-Axi, one with Cabo-Nivo at least, that have an OS benefit. And the 3 of them, in a way, yes, the combination are not against each other. The population are slightly different, but they all are in untreated metastatic RCC and all had the same control arm in sunitinib at the same dose. So a comparison is not completely 100%, unfair here. So if you start comparing a bit across the population, you see that, for example, the Keynote 426, which is Pembro-Axi, had slightly higher, maybe 10% favor risk. We know that risk group does well with single agent TKI and perhaps can explain the median PFS of 11 months with sunitinib in this group. The PDL1 is all over the place because defining PDL1 is really, really different. 25% consistent in the Nivo-based studies because that's the definition that the sponsor has. It's, tumor cells, PDL1, while in Keynote 426, the definition is different and involved in part immune cells. No difference here in terms of site of metastases. But I would say, interesting enough, while the rate of nephrectomy is 80% in the 2 trial already reported, Keynote 426 and CheckMate 214, so Pembro-Axi and Nivo-Ipi. It is actually lower in CheckMate 9ER. And you wonder if this is the Carmina effect and what the French did to all of us here with, their wonderful and landmark study of cytoreductive nephrectomy with sunitinib. So that's something also to consider here, because if you think about it, it's very hard to achieve a response or a CR in the primary. So that's something to note with CheckMate 9ER. When you compare result, of course, you can, you're still comparing apples to oranges, but one way which make it a bit fair is to compare result with at least similarish follow-up. Because it's hard to compare a study with 5 years follow-up to a study that just reported barely with 10 months follow-up. So if you put these around each other, CheckMate 214 was the shortest follow-up, which is still almost 2 years, with CheckMate 9ER and Keynote 426, which somewhat, if you put the follow-up, around the same time, you see a very good trend first, that overall survival is not reached in all and barely reached in the sunitinib arm on checkmate, 214. You see an intent to treat for a PFS that really not much to think about with checkmate 214, but quite similar-ish here with 9ER and 4 and checkmate and keynote 426. Again, the population is different. That could explain why sunitinib is 8.3 months with checkmate 9ER, since the favorable risk is 22%, and it's 32% here with sunitinib. Certainly, the hazard ratio is deeper and lower, double here with checkmate 9ER. So that's the way, and that's what I have actually for checkmate 9ER. And I wanted this panel, this esteemed panel, to start the conversation before moving to the next part.
Okay, thank you, Tony. Great presentation. I think that we want to to receive a lot of questions from the audience, but I think that we can initiate the discussions with us. I have a lot of questions about what you mentioned, but obviously the most option, obviously the first question that I have is, if do you have any particular patient, any patients that you will prefer treat with these combinations against other? Do you have any patient on mind based on this data, based on the progression disease rate in the first CT scan? Do you have any preference in the kind of patients to be treated with Cabo-Nivo?
So let me start first by saying, let's put VEGF IO versus IO. I think one thing that is coming to mind is with all the VEGF IO combo, and especially with Cabo-Nivo, the low rate of PD as best response. So we see patients presenting with metastatic disease. I don't want to say poor risk. I want to say high tumor burden in places where we know, I saw a patient the other day with like 10 liver metastases with pain. The liver capsule is, stretched with bone metastases, no cord compression, but I bet you in a few months this could happen. You could not afford here any PD. Therefore, you have to hit with all what you have, and you want a regimen that has the highest chance of any shrinkage with low PD. And I think this is becoming quite, people are following that paradigm. Having said so, we see all the time, from the time where we did not have VEGF IO, people being treated with IO, Nivo, Ipi, and getting a response. But I think now that we know more, that's what I think we should do. The other part is, one thing I didn't put because the data is not completely final, is the patient voice. So the quality of life. We are very, very happy that we're showing the patient voice initially and quality of life data early enough. Now, having said so, if you look at the Pembro-Axi quality of life, the questionnaires are different. The timing is not different, but the questionnaires are different. There could be different interpretation. So they're not the same, but clearly could be the dose, the Cabo 40 or whatever, the improvement in the disease symptoms. And that's why I showed you the Q twist with Cabo. And that doesn't mean toxicity. It's a mix of multiple, parameters. That seems to be superior. So Nivo-Ipi is superior to sunitinib. Can't say that about Pembro-Axi based on the data they presented, just compared to sunitinib on the trial. But Cabo-Nivo is good. And I really would love that study to dig more into component of quality of life to understand it better. So that could be a superior thing. I don't know what to do with bone metastases. If you go back to the presentation, I didn't mention it. Enrique was smiling when he's like, why didn't he emphasize? The same signal goes back. Progression-free survival in bone metastases, with Cabo treated is better, OS slightly better, but it seems to be better. Is that justifies Cabo as treatment of choice in bone metastases? Perhaps. I think there is enough evidence to say yes, but let's not forget, this is not Cabo versus, this is Cabo versus sunitinib, and we know very well this could be because sunitinib as a VEGF TKI does not do well in bone metastases. So, but there is enough data also to make this, reasonable. I would love, and that's something we discussed and we know will never happen, like, discussing myself, sitting with you outside, having a beer or a wine with some jamon, looking, it's not happening. It's over Zoom with, a silly cup of coffee here. I would have loved a large trial that has one control arm, sunitinib, and 4, 5, 6 combination, and let the best win. We know that's not going to happen. That would have been ideal in real time, like a stampede-like. And hopefully one day in kidney cancer, if we have multiple questions at the same time, we will able to do that. That would have answered most of our questions.
Okay, Tony.
Okay,
I think
these guys are very provocative, and this is a question.
They are. They're like Real Madrid fans. Not good.
So no, don't show this.
I can't do that. Will you leave the meeting?
We don't like it.
Okay. I'm invited. I'm gonna behave.
Okay.
We had a meeting 1 week ago with a friend of all of ours, with Tom Bowles, and he said, I'm not saying we think the same, but he said that Cabo Nivo and Pembro actually look like twins, and maybe well, we can focus on Cabo Nivo only in patients with bone metastases and leave the others for Pembro. What do you think about it?
Tom is obviously involved in all these trials, in the Cabo Nivo, in the Pembro axis. I think to make that assumption, you have to see based on what. I think, yes, it will be a good way to carve out a niche, etc. But I can't justify it. Someone else will come and said, well, about VEGF-IO, we have the best, quality of life. Therefore, you should go by that. I think also, just to make things, because you want me to answer yes, no, I can't, except in soccer. Just see how messy this gonna be with other trials reading. You all know that and I'm sure we're gonna talk about that. They're coming in my slide. The CLEAR study. There was a press release, I think this week or last week. This week. Yeah. About the CLEAR study. Meeting the primary endpoint in the pembrolizumab. We don't know the data, we don't know the details, it's perhaps, but that also gonna add another layer. And you could have twins too, but to have triplets, I mean, that is gonna be hard. So I will put it back on Dr. Powell's to see. That's why in my next presentation, you're gonna see some trials that are building on a standard of care, whether it's a VEGF-IO or IO-IO, so that we can move to the next step. Listen, we've been here before. I trained with Ron Bikowski, where we celebrated sorafenib as a huge win over interferon. And this was the biggest win. We looked at the hazard ratio, I believe it was 0.5, but although the PFS was less than 6 months, So having many options for patients is good. We'll figure out something. We'll figure out an algorithm, at some point. And we have to, but we may need to take cost in consideration. It may not be our call because we're not, but that's also when you add the drugs, the cost is different. And what I can get away with in the US or in Boston, or maybe in Spain, is different than another investigator, for example, in Turkey or other places. We have fellows we train from Turkey. They still have to, different ways how they process, drugs. So we have to be also, we have to remember that.
And Tony, You don't say any word about the combination of Abeloaxi. What about this combination?
No, I think this is a combination. Go ahead. Enrique has a question.
Before, because I think who was the senior author for the Javelin? Because I can't remember his name. Who was the senior author for the Javelin renal?
Oh, yes. Let me get my cup here. So let me, Pembroaxi, you asked. I mean, Pembroaxi first. And
No.
then I'll
No. Abeloaxi.
Avelumab Axi. So listen, Avelumab Axi reported at very same time, a few months before Pembroaxi, response rate and PFS in the same range. There's no doubt. But the OS benefit in terms of statistical significance, despite that the hazard ratio in the updated analysis we had in Annals of Oncology we published, it's still the same. It didn't get, closer to 1 like with atezolizumab, which went from 0.68 to 0.94. It's still around the same, I think between 0.78 and 81. But it doesn't have an OS. People look first and foremost at efficacy. Do I have patients on out of the trial? Absolutely. Well, OS, I think there is one more analysis left. And even if OS is achieved, will this be too late? When you have all other and doctors use the combination. So again, it's an embarrassment of choices. Unfortunately, we don't have, for example, if you want to move it to a different line, right? We don't have with Avelumab Axi any data, at least to my knowledge, in post-IO or in patients with significant prior therapy, which is now a growing segment of our RCC population. But that's why you do clinical trials. Why OS is achieved here, not there? Is there a study design? Actually, the baseline characteristic in terms of IMDC risk group between 90R and Avelumab is very similar, 20-22% good risk. Is it a PD-L1 inhibitor, PD-1 inhibitor question in renal cell, which now we have atezo study first line. Again, PFS, no OS. It could be, Enrique does very well, and he's one of the PIs on the atezo chemo, and he tells you that, maybe PD-L1 inhibitor have less activity, or maybe they are not better to combine. I don't know. The data is the data. And we think that, and then we're going to have a PD-L1 inhibitor study positive just to outdo what we said. But this is the data. And despite, the responses and this are good.
Alvaro, we have a couple of questions from the.
We have several questions from the audience, Tony. So if you wish, maybe just to jump before we jump into some different issues. There's a question from a colleague from Argentina, Jose Mauricio Peñaloza. Excellent presentation, Dr. Choueiri. Which one will be your best guess or your suggestion after progressive disease in the checkmate 9ER? I mean, after progression to Cabo-Nivo, what are we going to give to patients?
So after progression to Cabo-Nivo, and I'm glad because that will be my next part of presentation. I think the first question, is there any evidence to use IO from high-level evidence when the tumor progressed on Nivo? And my answer today is no. Despite all the data I'm going to show in this, there isn't. It wouldn't be wrong, but there is no level of evidence to continue with IO, very high level of evidence. I think TKI should be standard here, whether you give after Cabo-Nivo axitinib. It has activity post checkpoint inhibitor in retrospective studies, as well as in prospective study, Dr. Ornstein et al. In Lancet Oncology. Cabozantinib, you can't use again if you progress. I mean, but lenvatinib, everolimus does have activity post-TKI and most likely post-IO. They're reasonable. You're going to see some studies that are ongoing now and accruing, which I know with you guys, you really are a beacon of hope for Europe in Madrid and in conducting clinical trial. So hopefully we'll have some clear answers. But I would say what is not used before, and I usually go with single agent TKI. Now, one thing to add, we ran a study we presented at ASCO by the name Fraction RCC, which is a quite interesting platform where we have two tracks that went in parallel. And, you know, the idea was taken from lung also. And you have untreated and previously IO untreated and IO treated, or we call them experienced, just to change English. An IO experienced patient, you keep the Nivo and you had other assets, other new drugs. And one of them is ipilimumab. We found post-IO. So a patient, for example, who progressed Cabo-Nivo, Atezo-Bev, sunitinib, Nivo, Axi, then can go on that study. We found a response rate with Nivo-Ipi of 15%. Now, this is not very high, but at the same time, these responses were durable. Is this Nivo-Ipi or this is Ipi? There was no control arm. So I think in patients that, you know, don't have an explosive disease, you know, especially that Nivo-Ipi as a combo is approved, you know, that is also a something to consider. But again, it's a phase 2. And there was a retrospective study from Cleveland Clinic also that came up to the same number of response.
And Tony, one question. Would there be any patient profile that you would be happy by giving Ipi-Nivo? Because it seems like with the avalanche of VEGF-IO, this strategy seems to cover the whole first line of treatment for RCC. But is there any patient profile that you would give Ipi-Nivo and feel completely happy with that?
A lot of patients, I think it's reasonable if you're not progressing very, very fast and you have that, it's very reasonable. The tail of the curve, now that we have 4 years follow-up, is over 30%. But the population where I give it is the sarcomatoid, especially predominant. Reported CR rate, I believe 18 or 19%. Never seen that before with that combination. Although I would say that anything that has IO works in sarcomatoid, but that CR rate almost approaching 20% in hard to treat aggressive histology make me think Nivo-Ipi should be the standard in sarcomatoid predominant RCC.
And has a ratio for survival of 0.45. This is impressive, although this is, of course, a retrospective subgroup. You know, we have a very friend of all of ours who is...
It's Tom Powers again?
No.
No.
Fortunately, no.
In Spain, that he's the most active guy in the group. Okay, he's asking a couple of things, and I think they are very good questions, both of them. Do you consider that sunitinib on the 4 phase 3 trials that we have so far is the clinical outcome is different, or do you think sunitinib is the clinical outcome is similar in between these trials?
Yeah, I think the 4-2 is very appropriate, because when we change the dose with 7.5 continuously, that's a study that Bob Mozer ran. It was numerically inferior. That's one. Second, you may say, well, what about the 2-1 schedule? The 2-1 schedule, most of the data is retrospective. There's a very small randomized data that showed it's better from Korea. But then a phase 2 looking at just grade 3-4 toxicity was no different. So I would say that is the data. I mean, it would be great with TKI, in any TKI, to individualize the dose, because many people would say Axi-5 BID is inappropriate. You should start a bit higher and play with the dose as much as you can before saying this is progression. But how many people can do that? And, you know, not everybody has a practice which is exclusively renal cell and are comfortable doing this. So we have to go at a level, you know, that is, that is common. So I do not believe that the 50 milligram 2 week on 1 week off would have led to a different, different outcome.
And another question from Dr. Casinello. And this is in regards the toxicity or the tolerability of cabozantinib, 40 milligrams with Nivo. seems to be better tolerated than 60 milligrams as a single agent. Well, you are an expert in GRUPO CENTRO. What do you think?
Yeah, and no, I don't think as much tolerated as what happened is when the phase 1 was run. I didn't run the phase 1. It was at the NCI with my esteemed colleague and friend, Dr. Apollo. My understanding was, and you know, from the presentation, the decision was made on 40, despite 60 was not like, oh, no way, too many, you know, hepatotoxicity or other. No, because that led to those reductions subsequently. So we settled on 40. And honestly, with TKIs, I would argue that we don't know what is the dose of sunitinib in each individual. It's about the exposure, and everyone is different. Take axitinib. I have patients that are, you know, taller than me, bigger than me on Axi 2 BID with toxicity and disease held. And I have folks shorter than I, different BMI on 10 BID with some toxicity, tolerated tumor control. How's that possible? It's
But
not
this
the
is
dose. It's the
multiple.
exposure. And we don't know. We have to start from somewhere. We can't dose the drug in the blood or have. And I think 40 or 60 is appropriate. Axi 5 BID is appropriate. You have to start from somewhere. There are two schools of thought. People that would start a bit lower and increase, but then you risk here to lose a lot of patients and disease progress. You start higher and decrease. There is no right or wrong. You have to have a decision. So I do think 40 milligram Cabo is probably what did the trick with 9ER. And we didn't lose efficacy. I mean, compared to 50 sunitinib, was it with the help of Nivo or not, the PFS is double and the response is double.
And we have a question.
One more thing, Alvaro. There is a study that ran by our common friend, Dr. Paul, presented at ESMO with atezolizumab, which is a PD-L1 inhibitor with Cabo, also at ESMO. It was an oral. That part of it used 40, part 60. It seems that 60 has a bit higher PFS and response, but nothing that blow your mind away. Look, nothing. So it wasn't. I think I was looking. I even don't remember the numbers. I think the 60 curve was a bit higher, but nothing that shows this is a 12 versus 24 months PFS. Just to let you know, you could. I think in practice, what people should do, if this get approved, they should dose cabozantinib to patient tolerance. So if you have, after a month on Cabo, some growth, Cabo 40, some growth or stability, and no side effects whatsoever, it's not unreasonable to go up on the dose. And I've seen people going 40, 60 alternating. I've seen people going to 60. Because again, we don't know. Dr. Bjarnson from Canada had a long phase 2 where he increases the sunitinib to 87. Remember, Enrique, 87 higher, and found a small subset of patients that tolerate that and their tumor respond.
You know that we have Manuel Smith in Europe doing that for years.
That's true.
There's Javi, there's a very nice question from Eduardo Augusto Paz.
Well, that.
Yeah.
The second one.
Yeah, the second one.
Second
thought.
No, I was seeing questions about the role of the PD-L1 in patients in
You mean the
cancer.
stain?
Yes, because obviously we have difference between the definition of positivity across the trials, but do you think that they have any influence in the final results?
I don't think so. I think subsequent studies looking at PD-L1, you know, PD-L1 is an acceptable marker for VEGF TKI. People do worse on single agent sunitinib. But I think, you know, overall, it's way too complicated, despite it's a single time point, should be simple. Yeah. Different antibodies, different definition, different companies, different age of the specimen. And you see, even in Nivo-Ipi, where the signal is the strongest for their PD-L1, especially in intermediate poor breast PD-L1 positive, which, you know, the signal was that difference. Is it Nivo-Ipi or is it sunitinib not doing well? But we see benefit also in PD-L1 negative. So in my practice, I do not use it.
Okay. Okay. And you test it routinely in your labs?
No, we can ask for it. Sometimes it comes from second opinion from
Yeah.
outside. You get testing, you never answer. You would never ask.
Okay.
No, you answer, etc. One of the signals in PD-L1, although it's with the BMS test, if you go back to the 214, in patients that are intermediate and poor, that even have sarcomatoid, wow, the signal is even higher. So if you have someone, but I'm going to use nivo-ipi anyhow, right? In sarcomatoid, so it doesn't matter. But if you have someone where they have, let's say, an autoimmune disease, where you're going back and forth what to do, perhaps here, you can still use it and justify it, but not routinely. So it hasn't picked up in renal cell cancer much. On axiavilumab, actually, going back to that study, if you look at their PD-L1, which is 60% positivity or more, the response rate and the PFS is really not much different in the overall population or PD-L1 positive population.
The question, Tony, here is, one of the caveats when you are using IO-IO combination is that in the first, let's say, in the first part of the curve, well, you don't see that difference in terms of progression-free survival. Maybe some patients you are missing them, you can lose some patients in the first 3, 4, maybe 6 months of the curve. So the idea would be, why don't you use TKI-IO for 6 months, and after 6 months, or the time frame that you wanted, just to continue on immunotherapy as a single agent?
I think that's a possibility. Have to be tested in a trial. Absolutely, there's rationale, preclinical and clinical for it. But warning, I'm gonna warn you. So when we start thinking the same for IO, because initially we weren't trained, we were scared of 2 IOs, nivo and ipi. Instead of giving them together, we designed 3 studies. One was the German and the French, Titan RCC, to give nivo, and based on the response, add ipi. Another one was the HCRN, with Atkins and Hammers. And the third one was Dana-Farber with McKay and our group. And when we started by strategy of nivo, and if you don't have a good response, you add ipi, it didn't work as well. First of all, we lost a lot of patients. Don't forget that you lose patients. Some patients don't want to do any. That's one. Second, we didn't have this. We didn't have any CRs, barely. So we just published in JCO that the strategy of nivo followed by ipi, based on a response, to see if you can get away in a percentage of patients with one drug, less side effects. I wouldn't recommend it. You want to give nivo and ipi, give them together at the same time. Something that really we thought would work. I thought this would work, no doubt. They stay on nivo. If they don't respond, you add immediately the ipi. It's great. We lost CRs. We didn't have any CRs. So I think this to be tested in trial. We had during the TKI, you remember, my good friend Ian Davis in Australia did a study of sunitinib switching with everolimus, when what we had is TOR and TKI. Everolimus didn't work. And these are proved to be harder than we think trials. Bob Motzer did one of the record study where sunitinib you switch to everolimus, everol switch. And the message from the study is that we lost a lot of patients from step 1 to step 2, and that's in the same control the trial. So there's a reason why sometimes you need to give all your drugs, the best drugs first, when you have the best chance. Yes, toxicity more, cost more, but if you think about cure and solid tumor, usually they didn't come from one drug. BEP, CHOP, all these drugs together, there's a reason to target multiple pathways with multiple drugs at the cost of toxicity. I'm not discounting this.
Tony, I have a questions about the group of patients with a good prognosis, because I have a lot of doubts in that setting. Obviously, this is a heterogeneous disease, and many patients could be only making active surveillance or simple follow-up. Another colleague talks that this setting could be treated only with a TKI. What is your feelings about this subgroup of patients? How do you treat it routinely? You consider a combination of IO TKI for those patients with good prognostic group?
Depending on the endpoint you're looking at. So, you know, in a way, we're happy with the IMDC risk group and how we define things clinically in a cheap way with Dr. Hang. But on the other hand, we created a bit of a quagmire here. I think here you have to first take that IMDC risk group back and see what kind of population in it, because it is a bit heterogeneous. Are these patients with low volume disease? Because a lot of them are in the favor risk, not all of them. And then you would think, is it okay to do surveillance and delay therapy, or could you go for maximal surgical resection? We have cured patients, you know, that had an indolent biology. If not, we would have hit with drugs after drugs of drugs. That's the first question. The second one, despite your IMDC favorable in general, we've seen some dichotomy between IMDC favorable and significant tumor burden. So someone that comes for 4 years after, I have a patient, this is from the recent clinic, presented 3.5 years after the nephrectomy with stage 2 disease, with significant metastatic disease in the liver, lymph node, lung, 4 or 5 bone metastases. This patient just had, you know, has no symptoms, was discovered not even on a scan, you know, during a car accident, got a chest x-ray, some rib x-rays, and is fine, didn't have pain even. So this patient had normal labs, performance status, did a 5K before they saw me in the morning. And if you look at the IMDC risk group, this patient falls under favorable. You look at their scans, that was 18 months before, it was normal. Look at what they have now. That patient needs therapy. So I would dig more into it. And if you say PFS is a great endpoint, VEGF, TKI, you know, and IO work well, what we've seen is the OS at the first or second analysis from these VEGF IO study is, you know, we saw it with Pembro Axi is over 1. Nivo IP, the hazard ratio for OS is over 1, but you have a CR rate that is higher than sunitinib. So I think a lot of things can go. The first thing is you don't want to hurt that population that have a good prognosis for survival, but you also want to see if you can cure them.
Okay, just let me, if you don't mind, do the last question, and I think it's related to the quality of life, because I think the most unexpected data from the CheckMate 9ER was the graph from the quality of life. First, do you think these differences are clinically significant? And second, do you think that the curves may be different from the ones found at the CheckMate 214, in the sense that in the CheckMate 214, it seems that Nivo, when it's starting as a maintenance therapy, it seems that the quality of life of the patients is improving, impacting versus the baseline quality of life. And in the CheckMate 9ER, the quality of life curve is maintained in the same baseline level. I don't know if I'm explaining myself.
Yeah, you know, I agree with you. I mean, it's hard to compare which one are clinically relevant. You know, statistical significance is important. It's based on each metric that is different. Some of them mention that the clinical relevance, which, you know, you have a clinical relevance for the whole questionnaire, you have clinical relevance for one symptoms. Usually it's considered in many, like the 19th, KSI 19 at 3 points. If you look back at those graphs, there are less times where it's 3 points, but there are several times in both where it's more 3 points. So I would think, yes, but it becomes, you know, less and less. But that's something really, I think the message here is that we have to, when we have big trials, you know, we have to integrate the best quality of life and patient-reported outcome. That's something we have to look at. Unless we start doing the trial design I mentioned, with one arm experiment control and 5, 6, 9, and we add to the experimental. But something that's the patient voice. These are the patient-reported outcome. We talked about them for the 10 years. Now they come, and we cannot disregard them. They're imperfect, but we cannot disregard them.
So let's go to see the future. What is?
Can I take a 2-minute break?
Yes, of course.
Okay, 2-minute break. I just have a glass of wine.
No worries, we
Good.
Okay, do you want any jamón, something like that?
I say good Catalan wine or keep it for myself? Or
No,
then-
only a Ribera del Duero is a good option for you.
Okay, 2 minutes and I'll be back.
Okay.
Álvaro.
Oye, podemos aprovechar para decirle a la gente las siguientes reuniones que vamos a tener, Álvaro, si la tienes por ahí.
Sí, ahora mismo. A ver,
Para que la gente se pueda... Porque tenemos otro Meet the Expert durante este mes.
Sí. Tenemos, bueno, para que lo sepáis, tendremos un nuevo Creando Polémicas este lunes 16 de noviembre de vejiga, de cáncer de vejiga, y luego otro también lo vamos a hacer, bueno, multidisciplinar con compañeros de otras especialidades de cáncer de próstata el 25 de noviembre.
Eso es interesante porque vamos a tener un urólogo, un patólogo.
Y luego está planificado otro Meet the Expert el 30 de noviembre, lunes, en este caso con Daniel Heng, que yo creo que también va a estar muy bien para que lo tengáis.
O sea que tenemos
apuntado.
el día 16 a las 6 de la tarde, 25 a las 6 de la tarde y el día 30 a las 5 de la tarde.
A las 5 de la tarde.
Vamos a estar ocupados, ¿eh?
Sí, sí.
Bueno, gracias por las preguntas a todos. Habéis visto que las hemos hecho todas, todas las que nos habéis mandado se han hecho. Y bueno, pues a ver ahora qué nos depara el futuro. Yo no sé, no he visto, no tenemos la presentación, o sea que no sé qué.
No sabemos qué nos va a traer.
No.
Pero le voy a dar una sorpresa. Ahora mismo vengo. Voy a por una cosa que voy a coger del cajón.
A ver.
Ahora vengo.
Creo que ya sé lo que es, además.
Sí.
Tiene un problema, que es que, bueno, tiene dos problemas. Uno es que es del Barça y el otro, pues no sé si es la próstata o qué, pero... muchas gracias al doctor Casinello, que sé que me está escuchando, a la doctora Lourdes, que también nos ha hecho preguntillas por aquí, al doctor Peñaloza, que ya es un habitual. Doctor Peñaloza, usted se tiene que hacer del miembro del Grupo Centro. O sea, no vale solamente con asistir. Más cosillas. Estoy viendo por ahí amigos, Carlos Febres, a Sander, muchas gracias por conectaros.
Ya está. He ido a comprar un regalo para él, para luego.
Sí. Tony.
This is great. Tough crowd, huh?
I was defending you. These guys was attacking.
Don't worry, Tony.
That's what got me. But I have to tell you, based how FC Barcelona is going with their game and thing, it's
Tony,
not going to be a dynasty anymore, I'm afraid.
Tony, the group have 2 presents for you, okay? Maybe I can send to you to Boston. This is one of the presents for you. Without a name, maybe we can put here Toni Choueiri.
Oh, wow.
And the other part is that.
Like Zidane. Oh, man. Oh, man.
So this is a present for you, okay?
Oh, listen, I can't
The group
wait
is going to send to you to Boston, okay?
and be back together, all of us.
Okay, so let's go for the second presentation.
Let's do it. So I'm going to share my screen again.
Here you are.
And this is, and can you see now?
Yes.
But it's in the 2 slides. Okay.
What about this?
That's
Perfect.
That's
Perfect. Good. So great. And again, thank you very much. We're going to switch gears to looking this is a personal view about the future of RCC in terms of systemic therapy. Again, this is very personal. You can criticize as much as you want. This is my view of RCC the next 2 to 10 years. And of course, we want nice surprises, to happen. So these again are my disclosure. And this is how I think about the new approaches in metastatic RCC. So one way is we have approved the drug, but can we use them in different sequences, combination, and setting? Can we integrate the non-VEGF TKI and IO? Could we still imagine outside sunitinib a non-IO frontline option? I mean, is that even possible? Do we have room for other new VEGF TKI? And what to do with this? And we touch base on with one question from the audience about post-Cabo-Nivo, IO post-IO. And then the second part is talking about totally a new novel modality. So let's talk about what we know, but in a different way. So can we integrate VEGF and IO sequentially? And maybe we can in those middle of the road responses. And that's what Pedigree is going to answer. This is a study I co-chair with Dr. Zhang from Duke, which accept the fact that we have to start by a new option, which is one of the modern treatment, not sunitinib anymore. Here with in intermediate and poor risk, we start by Nivo-Ipi. If you get a CR, great. You continue Nivo for a year. If you progress, you get a TKI here, cabozantinib. But for those 70% estimated patients that do not have CR, do not have PD, have a response that is partial or stable disease, usually you continue nivolumab. But what if you add cabozantinib? Do patients live longer? So Pedigree is accruing so far in the United States. So the other question is, say, well, wait a second. We cured solid tumor by combination most of the time. I have the dear to my heart example of BEP chemotherapy. Why we don't, in an intermediate and poor population, poor risk and intermediate risk, not in the favorable risk, we give patient free drugs. So yes, they get Nivo-Ipi as control, but then we add cabozantinib at 40 milligram once a day. And that is Cosmic 313, that is also accruing overall with primary endpoint PFS and OS. All these are in untreated trials, RCC patient with clear cell histology. And one thing we try to do at the same time is variant histology RCC, which is 10 to 20% of all patients. This always lagged behind, and we apply the data in clear cell RCC with either retrospective study or even phase 1, phase 2 study. So what we're doing here, this is study led by Dana-Farber, open in few sites, led by my colleague Brad McGregor, Colonel McGregor here, which is in 40 patients. We get single arm study of Nivo-Ipi and cabozantinib in these patients with non-clear cell RCC. The study just opened last week. It involved also a few other centers outside Dana-Farber. So one question is, could we imagine a day without a frontline with IO? And I want to remind you of this study. We talked about it, this clear study. We had a press release just when I was finishing my slides. We had a press release, but this study is a 3-arm study, one of the last study that had sunitinib as control arm. It has a VEGF IO, lenvatinib, and pembrolizumab. Lenvatinib is a VEGF TKI that has also other inhibitory function against kinases like FGFR inhibition, which is involved in part in resistance to VEGF receptor inhibitor in preclinical models. But it has an arm of lenvatinib and everolimus, which is a non-IO arm, over 1,000 patient study, and just 1110, and we are today, just 2 days later, So 2 days only at 6:45 a.m., press release showing that the pembrolizumab, so this arm, the IO arm, had a PFS, OS, and overall response rate benefit over sunitinib. But the non-IO, the len-everolimus, E plus L, has also a PFS and response rate benefit. So this may be coming, just to be aware of here. Also, new VEGF TKI, I know it's approved in some indication in Europe. That's tivozanib, which is a clean VEGF TKI. Remind you about this study led by our friend Brian Reaney here in patients who progressed on prior TKI, including prior IO. They received sorafenib as a control arm versus tivozanib. And the primary endpoint of progression-free survival was met here. Median progression-free survival was superior, statistically significant with tivozanib over sorafenib. And that's my favorite slide, showing at 12 months and 24 months here superiority. And the OS was not significantly different here, and the hazard ratio, unlike PIVO-1 study, was less than 1. I think this was presented by Dr. Montipal here. So what is the future of this drug to be determined also? One thing also asked about is that, why can't we use Cabo-Nivo, Pembro-Axi, 5th, 6th, 7th line after IO? What do we see? Is there an IO after IO, TKI after TKI work? What about IO after IO? And first of all, there is a clinical potentially rationale. I remind you about Emotion 150, that randomized phase 2 here of sunitinib, monotherapy atezolizumab, and atezo-bev, that there was a crossover in that patient on sunitinib or atezolizumab that progressed. Then you switch them to atezo-bev. But if they're on atezo, you just add the bev. Interesting enough, here you can see a median PFS of 11.7 months here with atezo-bev post-atezo. It's hard to imagine that bev alone would do that, not impossible, but also response rate of 27%. So is this a signal that IO, continuing the IO has any, value here? Now, we looked retrospectively in this paper with one of our fellows, going to be junior attending, Dr. Ravi. We published that at the same time as ASCO. We looked at immunotherapy re-challenge from multiple institutions here in patients with renal cell cancer, 69 patients. And there are 23 patients that had single agent IO, Pembro, Nivo, mostly Nivo. And these patients' tumor progressed on prior IO-based therapy. And we saw that 7 responded. Again, this is retrospective. So responses are possible. We have this study with Len and Pembro prospectively showing a response rate of 58%, PFS almost 12 months with Pembro-Len post progression on prior PD-1 inhibitor. Now, you could argue that this is all lenvatinib in theory, because we see responses with axitinib, we see responses with cabozantinib post-IO. I don't want to compare across trial to say, look, is it up to 57%? But it is a possibility, but you cannot, ignore that pembrolizumab could have a significant contribution. You do not know that. Now, going back to the lab, switching from a PD-1 to a PD-L1 inhibitor, does it make sense? Well, maybe. And this is what I wanted to show you. I did this slide in collaboration with one of my close colleagues and friend, Gordon Freeman here at Dana-Farber, just to bring us back to a bit of basic. And this is an extremely oversimplified slide. So one of the things about the PD-1, PD-L1 axis, so consider this here, this interface. This is the antigen presenting cells, okay? And this is the T cell down. So yes, we are very aware of the PD-L1, PD-1 inhibitory interaction. But PD-L1 does interact with CD8, that's B7-1, in cis, not in trans, so on the same surface, if you want. And that interaction is a negative, is inhibitory, because CD8, you know, is, if you want, a positive signal. So this is really a typo here. This is a positive signal. So CD8 and CD28 is a positive signal, not a negative signal here. And PD-L1 interact in cis. When you inhibit with a PD-1 inhibitor, you know, that is left out. Could perhaps that affect the CD8, CD28 signal? And that's where a PD-L1 inhibitor here leave this positive signal going, and perhaps that is the preclinical rationale in a very, you know, a simplistic way. And hopefully that study, a randomized study, gonna tell us, this is a study post-IO that brings a PD-L1 inhibitor with cabozantinib versus cabozantinib only. It's a phase 3 trial here with primary endpoint PFS and OS, and that it does allow some of the non-clear cell histology. So that's another way will prove at a high level of evidence, if this trial is positive, that the PD-L1 inhibitor is okay to use after progression on prior PD-1 inhibitor. So this is how I look at the available thing. If we had no new drugs, no new target, nothing new. But there are actually new modalities and a new target. I want to start with something dear to my heart, which are the HIF2 inhibitor here. And this is a figure of a HIF. This is just a recent article last month that I authored with Dr. Kalin here about the HIF2 VEGF you know, pathway to show you that now we have HIF2 inhibitor. And why till now? And I don't need to rediscuss the role of HIF2 inhibitor as a master transcription factor that control many of the downstream target like VEGF and other. We've been doing figures like this for years and years and years in our review article. But why now? We always knew that HIF2 is great to target, but you can't target. Simply, this is a transcription factor. And take a look here at the top right. So how a transcription factor works. These are very, very hard targets. Why they're hard target? They're hard target for what we have in terms of tools, meaning for small molecule inhibitor, because with few exceptions, they're a bit sinister, if you want. They lack those classic small molecule friendly pocket where the drug goes. How do they do their business? Look how they do their business, by protein-protein interaction, protein-DNA interaction, by these, if you want, featureless surfaces or the helices with the sided chains that reach into the DNA grooves, you know, to make sometimes base-specific contacts. So this is really hard to target, but at the end, through some very elegant, groundbreaking, if you want, crystallographic work, a pocket in HIF2 was identified in the PAS-B domain that could accumulate in a small molecule. So then the heterodimerization, because HIF2 alpha need to dimerize with its partner, HIF1 beta, and that lead to the transcription of multiple genes. But then this small molecule could inhibit that dimerization, actually. So that is the story a bit. The first compound here was 2385. That's not the final compound. We did a study here with UT Southwestern, Kevin Courtney, who was at Dana-Farber. And this study was in heavily pretreated patients, median number of prior line of therapy 4. Well, response rate were low, but as a proof of concept in a drug that came out of nowhere and a totally new target, you know, 13% response rate. But what we found that this is imperfect. This is not perfect. This is not perfect because the exposure, this drug, there's a lot of patients who didn't have the right exposure. And if you look here at day 15 exposure, if you have a good exposure with higher, the cutoff is 0.5 microgram per milliliter here, your PFS is much, much better. So then people went back to the drawing board and came up with a drug that has a better pharmacokinetic profile, better binding to capacity, you know, less ubiquitination if you want, and you know, the metabolism is you know, less degradation, and came up with this drug MK6482. The compound was called PT2977 when it was a Peloton compound. Now it's a Merck compound. And in a similar study of heavily pretreated patients, the response rate went up to 24%, and 70% almost of patients experienced tumor shrinkage. So elegant chemistry work. Now you may say, well, okay, this is coming, but what's the toxicity? How are you going to combine? Well, the toxicity is different from VEGF inhibitor. So it seems to be well tolerated. The discontinuation because of treatment-related adverse event is low. There isn't much diarrhea, hypertension, cardiovascular event. There is anemia, which is on target because one of the downstream target of HIF2 is erythropoietin. So the anemia is on target. Usually it's lead to those decrease, but most of the time with transfusion and with exogenous erythropoietin, you know, patient can raise their hemoglobin. But interesting to keep in mind in this drug, which is came with the first compound, and the second compound is hypoxia. So we have to talk 2 seconds about hypoxia here. Well, most of it are, a lot of it is low grade. Luckily, it wasn't associated with cardiac or pulmonary complication. But why hypoxia? Because, you know, like with VEGF, HIF2 also has physiologic role, and the blocking it may exacerbate any ventilation perfusion mismatch and any acclimatization. So this is elegant work here from Sir Peter Ratcliffe, who shared the Nobel Prize last year with Greg Semenza and my mentor, Bill Kalin, on their work on oxygen sensing and hypoxia, coming from different angle, each one. But Professor Ratcliffe group here treated, you know, these are mice here. And when you treat them with the HIF2 inhibitor, you know, here, when you have hypoxia, normally here, you know, you increase your ventilation as a way to, you know, for acclimatization. But then it's when you have the compound here and you have hypoxia, the HIF2 inhibitor, you do not have an acclimatization in ventilation. So what does that mean? You know, you have to be careful if patient is borderline, have lung disease, pleural effusion, significant pulmonary disease, or sometimes high altitude, which a lot of people, you know, do well, fine on high altitude if this is, you know, their life and they get acclimated to high altitude. We know if even Spain, the mighty Spain national team in soccer, if they go play against Peru, you know, they're going to have trouble, you know, but the Peruvian players will not have, you know, troubles. But if you give a Peruvian player perhaps a HIF2 inhibitor, that acclimatization go away. So we have to be careful going on with this. We have a phase 3 trial open in many countries here, testing the compound against everolimus, but that's post-VEGF TKI, post-PD-1 inhibitor, up to 3 prior line of therapy. And hopefully that will lead, hopefully, to a new drug. A glutaminase inhibitor also being tested. That's really good thing because this is really targeting metabolism. We know a genetic alteration in the fundamental metabolic pathway of tumors lead to an increase in the glucose intake. In renal cell defined metabolically, you know, there is a switch to lactate rather than the TCA cycle, if you want. And that lead to a cancer cell then depend on glutamine. And that enzyme inhibit the glutamine to glutamate transformation for the energy. That's the glutaminase inhibitor that I will never be able to pronounce, but I'm going to try now. Telaglenastat. So CB839. It's always nice to have numbers. there is preclinical evidence of synergy with multiple TKI and with everolimus. So there are some elegant work you can see here. And actually, there is a randomized phase 2 trial, very small, 2-to-1, presented at ESMO, with the combination with everolimus versus everolimus in previously treated patients. And as a proof of concept, despite the absence of responses much, as a proof of concept, the study led to a doubling of PFS. And despite the confidence interval here you see, this was judged to be statistically significant based on the pre-established condition, you know, in a one-sided p-value. So hopefully a much larger study called a phase 2 study, but over 400 patients, randomizing patient to post-PD-1 and TKI to Cabo versus Cabo and the glutaminase inhibitor. This study finished accrual. Hopefully we'll have some results soon. And if it's positive, honestly, it will add a totally new compound, a totally new way to treat the drugs. It will open multiple avenues with drug development on glutaminase inhibitor and other elements that deal with metabolism, which actually will be also refreshing. Now, the last one is, to me, is there's a lot of immunotherapy there. And we're all suddenly become overnight, all of us here, immunologists, because we want to bring the best to our patient. We will learn it. We want to do better for our patients. So what are some of the immunotherapy strategy here? Invested in renal cells. So, you know, there are other, I wouldn't mention because the data in renal cell either non-existent or just showed that are not called PD-1 and CTLA-4. And now how I see this is other cytokine, you know, beside high-dose IL-2, vaccine or cell-based therapy, new checkpoint, or things around the metabolic pathway. I'm sure you can add 7 or 8 and call it other immunotherapy, but, you know, in 20 minutes, I want it to be focused. So Nectar-214, you're familiar with. It's a pegylated IL-2. So this is IL-2. Interesting enough, it binds to the beta-gamma dimer rather to IL-2 receptor beta-gamma rather than the alpha also. And hopefully this will lead will lead to not having immune repression, because conventional IL-2 has affinity to the trimeric, not to the dimeric receptor, and led to enhanced response, not to mention the pegylated, which, you know, gives you less toxicity and is an outpatient treatment. So initial combination with nivolumab showed a response rate of 46%, including 26 patients with renal cell cancer here. And this led to a phase 3 study with Nivo plus the pegylated IL-2 called Nectar-214 versus either sunitinib or cabozantinib. This study, to my knowledge, is open and accruing patient. And that is the study design. And the name is Bempegaldesleukin. So, you know, I do have some sort of dyslexia with these names. So hopefully this is RELAS trial that uses sunitinib as control arm. At least here there is cabozantinib, but I think this trial was, you know, started soon as the other trials were reading. You know, this is another a compound in IL-12, you know, that is also interesting. It's coupled with NHS76 that direct the IL-12 to the tumor micro environment here and is released by necrotic tumor cell. So there is a phase 1B in combination with avelumab. IL-10 is another cytokine that is also pegylated, showing 25% monotherapy response rate, but only in 16 patients here. To my knowledge, no phase 3 planned with this compound, but something where it was used, and more so recently in renal cell cancer. Now, vaccine-based approach, I have no doubt that this field gonna explode at some point. I wanted to put two examples here. One is a Neovax, which is a study at the Dana-Farber. It's a personalized peptide vaccine from predicted binding tumor neoantigen coupled with an adjuvant here. And another one from the NCI was Childs and Nadal here, which is, and Nadal from Barcelona, I believe, which is a TCR gene transfer. It's an adoptive infusion of T-cell receptor transduced T cell. This is beautiful biology here based on the fact about the recombinant, herb here. This is the Neovax, a study that we have. It's coupled with low-dose ipilimumab subcutaneous. It's a lot of work. So when you have vaccine, etc., some of them off the shelf didn't do well in trials. These need extra work. This is the amount of work. But in summary, you take the tumor and you sequence it and you come up with what you think based on expert, what are the predicted HLI banded peptide the most here, the epitope, and you make this as a drug. You synthesize them. You give them to the patient with an adjuvant, and here we're giving also local ipilimumab. There is data, preclinical data, of enhancing the immune response, also of multiple type of immune cells with local ipilimumab, and it's certainly less toxic. And we have a DoD grant around it, and that's Dr. Nadal's study. That's a slide courtesy of her. That's also a beautiful story, beautiful biology, that endogenous retroviruses is 8 to 10% of the human genome, and antigen derived from this provirus could be immunogenic and stimulate cytotoxic T cell and killing of clear cell RCC in vivo and in vitro. So the team here at the NCI that has that expertise developed a trial in exploring adoptive infusion of HERV TCR transduced T cell and clear cell RCC. They did a study with bone marrow transplant in the past, and they isolated the T cell from a responder, and they found the T cell patient do respond. Actually, they were against the endogenous retrovirus, which is in our genome, 8 to 10%. So this is really, really personalized and quite promising. So I did this here with my postdoc fellow Ziad Bakuni here, just to show you that there are multiple, and this is a dendritic C cell, T cell, cancer cell, multiple other checkpoints are under investigation in addition to PD-1, CTLA-4. This is very simplistic interface here. Remember, you have agonist in 4-1BB, OX40, you have an antagonist, and that's, the TIM3 and other. You have LAG3 here, which really can be engaged in immunostimulation as well as immunorepression. We don't have, these are the immune activator, these are the immune repressor. LAG3 is pleiotropic. We don't have things at the level of, phase 3 or randomization. But this is the data in RCC. This is 4-1BB and the LAG3. There are some data, presented here. This is with ipilimumab in RCC. The response rate seems always to be in line or higher than the single agent PD-1. And this is the IMP321, which is a LAG3 fusion protein. Didn't show responses in a study from 10 years ago. So people were thinking like that, but before the PD-1 inhibitors, nobody even looked at that literature. But guess what? We have new LAG3s now, and they're being investigated, usually as part of larger basket study. Again, this is a simplistic interface between the dendritic cell, the T cell, the tumor cell. But what I did here with Ziad, I added the stromal cell, focused on the adenosine and tryptophan pathway. here. And this is an important pathway to keep in mind. You know, the amino acid tryptophan leads to kynurenine, which kynurenine is an immunosuppressive, a very highly immunosuppressive metabolite in the tumor microenvironment. And that reaction is under what? Under IDO. So that's where the IDO inhibitor comes from. It's under the IDO, you know, overall. On the other part, again, relevant to the immune microenvironment and a bit almost along the similarish pathway is the adenosine pathway. And, you know, everybody knows the ATP and the metabolism from ATP to AMP to adenosine. Adenosine also is, you know, immunosuppressive, very immunosuppressive. And these are all under, you know, CD73 and CD39. That's how the conversion happened. So targeting CD73, CD39, A to AR could lead to inhibition of the tumor microenvironment that is immunosuppressive because of adenosine. Again, this is almost the same story here. Now, what do we know clinically and preclinically? That we know that kynurenine, as I mentioned, is immunosuppressive. We did a study here, actually specific to renal cell, with my mentee who won actually a career development award through ASCO with this, where we looked at data early on from renal cell and melanoma, and we found that when patient, this is week 4 and week 6 melanoma, week 4, week 6 renal cell, when you treat with nivolumab, pre and post, this is measured in the blood here, you know, these immunosuppressive metabolites, the kynurenine work, go up. So this is a mechanism of just in response to nivolumab, this is countering nivolumab immune stimulatory event by this immune suppressive molecule in the tumor microenvironment. And when kynurenine goes up, and it was relevant going up in all, you know, in melanoma and renal cell, this is associated with a decrease in progression-free survival. Now you may say, then, IDO decreases that conversion. So, you know, IDO inhibitor were great, right? IDO inhibitor, we all familiar with this data 3 years ago from Lucky Lara, where we saw 47% response rate in patient with 0 to 1 prior line of therapy, and led to a phase 3 study of PD-1 plus IDO inhibitor versus a TKI. But since the whole program was stopped because the data in melanoma was completely negative. So what happened here, should we have gone with a selected population? So based on our data here, let me see if I go back here, should we have gone in those patients? Not everyone had an increase in kynurenine. Should we have gone with the PD-1 IDO inhibitor in patients that had an increased kynurenine only? Not every patient had that reaction. Or is there better IDO or TDO inhibitor? And this is being worked out. And some of the last slide here is focusing on the adenosine pathway. These are the other IDO inhibitor, by the way, or targeting, the story. But I wanted to show this pathway here, targeting CD39 and CD73, and show you adenosine is immunosuppressive. And I showed you the metabolism of ATP, AMP, adenosine here. We know also that increased CD39 and 73 is associated with poor prognosis. And again, same thing, CD73 expression goes up in PD-1 treated versus PD-1 naive. And increase in adenosine in some patients, if you have an increase in adenosine in your after nivolumab, it's also associated with poor prognosis. And this is some very elegant data now published. I didn't upload that slide in Cancer Discovery with an A2AR inhibitor. called CPI 444 from Corvus, where there are responses with single agent or in combination with atezolizumab. And this is another avenue here. But this is just one part. There are other here. This is a drug that is an A2AR inhibitor. You can say, well, I want to do it ahead and inhibit CD73 or CD39, and this is all gonna come in RCC, but is going to be first in earlier studies. So hopefully the take-home message here is that first we're gonna integrate known drugs from phase 3 trial, and hopefully many patients will be on trials. And I believe the post-IO setting is an unmet medical need where we're gonna try all these drugs, whether the same drug to see if they work, or totally new drug that are, I call them IO-ish, IO-like, or totally novel like HIF2 inhibitors. So wanted to present our GU as of this fall. You have more time now that you have COVID to make some slides. This is the Dana-Farber Cancer Institute GU, the Lang Center, which I have the honor every day to lead, with our 23 GU medical oncologists here focused on cancer. And I have to say, despite I'm a Barcelona fan, that's my team here. This is one of my favorite places in Europe. I could spend the whole day and come back, and that's why actually I come the day before and leave the day after to a meeting in Madrid, Mercado de San Miguel. So this is here with my some of my mentees, the two Canadian here back to Canada, Alejandro Lani, Dominique Bosset, and our clinical director, Brad McGregor. So instead of being here with you, I'm stuck. I snuck a picture here from the beginning, and we're doing Zoom, and really, hopefully, we can be together at some point. So I'm gonna stop sharing and go back to this, and really thank you for this invitation.
Thank you so much, Tony, for just such an extensive view of the future of RCC. And well, there could be a lot to comment. So just to begin with something that, as you said, may come closer in the near future, which are the glutaminase inhibitors and the telaglenastat, because the expectations were somehow higher, but then with the Entrata trial, with the everolimus trial, at least in my opinion, they may have gone a little bit down, because everolimus is a poor competitor, poor standard arm. But even though the upper limit of the responses with the combination of telaglenastat was not so high. So I mean, what are you expecting to find in the Cantata trial, given that Cabo is a very active agent by itself? So what will telaglenastat add to Cabo in this setting?
I think here you have to look at the whole data, despite that this is, despite that there's a randomized phase 2, it's over 400 patients. I think the first that it is not another PD-1 or a VEGF-R blocker. It's a totally new drug, a totally new target. I think, to me, trying to develop drug in renal cell cancer and GU cancer is a very positive thing to the field. So even the first one, remember with TKI, we went from sorafenib to axitinib, cabozantinib, levantinib, which are definitely better TKIs, they be. So hopefully we'll develop the next drug if the results are positive but not convincing. On the other hand, you saw a proof of concept. There is no doubt in a randomized phase 2, despite the absence of response. So I think we're gonna look at the whole data and dissect it. I'm very excited about it, positive or negative. I can't predict anything. I'm gonna answer this question. Someone is accusing me that I don't know that Mercado San Miguel is in Madrid. I do know that.
This is very interesting.
And maybe I'm a Madrid fan, but I'm not telling anyone. I do think the top 5 players in the history of football, that Zinedine Zidane should be considered one of them. By the way,
great.
So I know that. So
I agree with you, Tony. I have a questions about the personalizing medicine in RCC, because in many tuners, we are moving to these kind of approaches. And well, this year in ESMO, we have the result of the French group with the bionic trial. What is your feelings about these kind of trials, designing and try to, well, individualizing therapies? Because you have mentioned a lot of trials, but without any biomarker in that.
Yeah, no, I think that's important to send a message that we can do these trials. That's the first message in real time. It only can get better. We just lack a biomarker, and we may never find it. Just to be, for someone that all my translational work is about biomarker, we may not find it. Not that we find it or not, it may not be relevant enough to change practice. So PBRM1, post-nivolumab, VEGF-TKI, and it counts you all the immune signature. Even actually the best work that is closer to clinic is the angiogenic signature with sunitinib and VEGF-TKI. That's the strongest signal. It's not the immune signature with IO. It's something that, but we're not, are you gonna do this and give single agent sunitinib? You know, it depends on the signal. It has to be very strong, very relevant, very robust, very reproducible. It cannot just be one lab in Madrid that does it for the rest of the world. And this has not happened, but at least people are thinking, you know, differently. I can tell you, when I started my career, you know, at the Farber, I wanted to do translational studies from published, you know, published trial, like, you know, the sunitinib interferon, the sorafenib. I can tell you a lot of these studies even did not save tissue. I mean, this is not, it doesn't, now it happens routine. It wasn't even safe. There was one slide. So I think we're at a better place, but we have to accept the result. If the amount of work we put in these studies that are done largely in academic groups, like the bionic trial, largely, but not exclusively, you know, where we put a lot of work, we have to accept some of the trials, most of them could not change clinical care. That's one. Second, a lot of the field is going toward combination, partly because, you know, of studies like Omnivore and others that didn't, you know, find that sequential, and record 2, I forget the number, record 2, I think, Bob's study of sunitinib everolimus didn't pan out. So people went back to combinations. And now you've seen VEGF IO 50, 60%, VEGF only 30. So people are going, Nivo Ipicabo, you're combining. So when you have that and 3, 4, 5 drugs, then if there is single unidimensional biomarker, probably less. And, you know, look at BEP and SHOP. Do they have a biomarker? Folfox in colon cancer? No, I would say no. I mean, there are contraindications to what not to receive. On and on and on. So I think I'm hopeful, but I also want to be realistic.
Okay.
Toni, what do you think? Well, first, congratulations for this impressive, I would say. We are very honored for have the opportunity to see you talking about the future. They're really impressive, honestly. What do you think about the adjuvant setting? What can we be?
Great. So your talk, thankfully, you made it easy for me, those 2 hours talk about metastatic disease, because, you know, my view about adjuvant, anything can completely disrupt, like COVID. Anyway, I shouldn't be making comparison with something that negative like COVID, but can disrupt. Because, you know, you all know that adjuvant TKI did unfortunately fail in renal cell cancer. There is one FDA-approved drug, sunitinib, but then, you know, there is no overall survival benefit. There's a quality of life issue. And then other TKI, supposedly the same, if not better, large trials were negative. The source trial actually of Tim Eisen was just published. I had the chance, I think it was in JCO, I read it quickly the other day. It really is negative at every juncture. And this is a drug that went into the system because there is toxicity. There's a significant toxicity. So I think if the IO studies are positive, and we have 2 studies that finish accrual with atezolizumab and pembrolizumab, powered enough, that cannot change how we treat the disease. But there's a problem here. There's a problem with adjuvant I always have, that this is not like lung cancer or pancreatic cancer, that there is a subset of patients in the highest risk, even lymph node positive high grade, that is cured with surgery only. And it's impossible at this time to identify those patients. We and many other groups are doing elegant work with circulating tumor DNA, whether using next generation sequencing capture, using personalized DNA alteration capture, using methylated DNA with my partner Matt Friedman here and Jake Bershok and Pierre Nuzo. And we think hopefully we'll arrive to a setting where we can detect MRD after a curative intent surgery, because you could have, in theory, a stage 1.5, 1B that will recur, that hopefully we can detect within 3 months in a blood test, urine test, whatever. And you could have a stage 3B that is cured with surgery only, because you don't know these cancer cells at the time of surgery where they are. But if you end up giving an adjuvant therapy in everyone, because the results are in everyone, what's going to happen? That's another problem that, it's a good problem to have. The first thing, we need a positive study in the adjuvant setting. So when these studies going to read, I don't know. They usually take time. But Enrique will tell you, who does bladder, you all do bladder cancer, that we saw. I was surprised to see in Vigor 010, Enrique, the numbers. I have problems. Negative. I didn't think it's going to read that early, but half of the patient had lymph node metastasis. That's with Dr. Hussein and Belmont. And we saw with Dr. Galsky the NIVO study, checkmate 275.
274.
Oh my. Just say yes, just one number. Positive. I expected these studies to take more time to read. Either they are really higher risk than we think, but they're positive. So what's going to happen to a front line? What's going to happen to maintenance avelumab if you had a prior adjuvant?
But so, Toni, the checkmate 274 is positive for disease-free survival.
I agree.
So do you think that disease-free survival, because ESTRA trial was positive for disease-free survival as well, and this is not considered routine practice, do you think a disease-free survival impact of Pembro or Atezo in kidney would be enough to get it used in the clinic?
So it's a fair question. I have to see the data. I'll give it back to you. Let me tell you what. A disease-free survival in the range of ESTRA with an OS hazard ratio of 1, with a decrease in quality of life, I would say probably no. Probably no. But a disease-free survival without OS at the first interim analysis, like the adjuvant ometersenib study, osimersenib, the EGFR inhibitor, where the hazard ratio was like, I think Roy Herbst presented that was 0.2.
Yeah.
Or a disease-free survival in an adjuvant setting like the Pacific trial with durvalumab. We know the OS came later. If the same setting happened in kidney cancer with a checkpoint, I think I'm going to adopt that. So it depends where you are, but a DFS of 0.8, statistically significant, with an OS hazard ratio of 1.1, with a 1 year of a checkpoint inhibitor cost and a detriment, let's say, in quality of life and toxicity, I am not sure, even if I get into adopting this, I'm not sure other people will. So you are totally spot on, and I would love to see how the data is and how it will mature with time. But you are spot on, Enrique.
I think that we have only 2 minutes, but I want to finish this webinar asking you about the ASCO elections. But you are one of the candidates for these ASCO elections. So, and many of the oncologists, right, in Spain are members of ASCO. Do you want to say any word to them?
You mean I cannot? I want you. I cannot compare. I mean, if I did anything, is everybody is mad at me because of of Barcelona. But I want you to know, we had in our group Joaquin Belmont, a great friend. So there is this, there is, there is the wine and all that. And, I visited Barcelona many years ago when Joaquin was with us, and 10 years ago, and he took me to the stadium. No one from Madrid did. And, I grew up watching, that golden team that had Ronald Koeman, Andoni Zubizarreta, the goalkeeper, you may not know. And Johan Cruyff was the actual coach. And this was just pleasure to see. And the other thing is my neighbor back in Lebanon was a hardcore Real Madrid fan, and we used to fight all the time. So I took that to the next level. But you have a great city, great people, certainly one of the best team ever in the history of soccer, Real Madrid. I cannot deny that, whether I like it or not. And really, hopefully this COVID make you think a lot about the friendship you made, about everything, including your existence. So I cannot wait till this really finishes and have a meeting in Spain, in Madrid, have an ESMO back, in Madrid one day.
Okay, thank you, Tony. So
hopefully next time we will meet in person, inshallah.
Okay.
Or we you are in the middle like Sevilla, who's getting not bad in soccer.
Okay, could do that. So we know that you are a very busy man, so we appreciate a lot your effort to stay with us today. Thank you so much, and we will hope that you stay safe, you and your family, and we will see in the next year, hopefully.
At some point.
Thank you so much.
And thank you, and you guys are all big, happy family, and hopefully together against GU cancers and COVID. Take care.
Thank you so much, Tony.
Thank you. Take care. Bye bye.
Thank you so
Muchas
much.
gracias a todos por estar ahí. Esperemos que os haya gustado. La verdad es que hemos tenido algún momento con más de 80 personas conectadas, lo cual muchos de ellos son compañeros oncólogos. Habéis tenido la oportunidad de preguntar a una de las personas, yo creo que referentes, ¿no? A nivel mundial sobre cáncer de riñón. Espero que os haya gustado y nos vemos el próximo lunes. Lunes 16. Gracias a todos.
Gracias.
Hasta luego. Hasta luego.